right, so good evening again. Thank you for joining us and welcome to this evening's program. I'm Jamie Seward. I'm an Associate Director of Affinity Engagement Programs with the Office of Alumni Relations here at Johns Hopkins University. Now, before we proceed, I'd like to acknowledge our co-sponsors, the Department of Neurology and Brain Sciences and the Healthcare Affinity. Now, before I turn the program over to our moderator and our speakers, I encourage you to ask questions by typing them in the Zoom Q&A, which is located at the bottom of your screen. We'll have time to answer your questions at the end of the program. Now, I have the pleasure of turning the program over to Dr. Llinas and Dr. Arthur.
Hi, my name is Rafael Llinas. I'm a professor of neurology at Johns Hopkins Hospital, and I'm the program director for the Neurology Residency. What I thought I would talk about today is medical education and how there's changing times and how there's changing learners. And I'm very happy to introduce Dr. Karissa Arthur, who's also on the line with us. She is one of my executive chief residents in neurology at the Johns Hopkins Hospital. How I thought we would do this is that I would talk a little bit about the history of medical and residency training, and then Karissa and I would sort of have an organic conversation about medical education, what's worked, what's not worked, issues in the past, issues in the future, and especially issues with COVID, issues of empathy and professionalism and humanism. Hey, Karissa, how are you?
Hi, good. How are you?
Good, good. Thank you so much for joining me. I really appreciate it.
Yes, happy to be here.
So listen, as Karissa will tell you, all my lectures have to start with a little bit of history, not too much and not too painful, but it's good to know where we are a little bit. First slide. So we're just going to talk a little bit about how medical education has been in the past. So really, you know, in the 18th and 19th century, being a physician, you were basically an apprentice. You didn't need a university education. You didn't actually even need to graduate from high school. You didn't need to be able to read and write. And one of the things that Johns Hopkins brought to that was Elizabeth Garrett, who is one of the founders of Johns Hopkins, insisted that people were entering medical school at Johns Hopkins had to be able to speak and read and write German and French and English. And that sounds like a lot, but you have to remember, to some extent, there was a segment of physicians that were almost illiterate. And so it really began the concept of physicians being academics and being scientists and being curious and reading the literature. You know, in a lot of ways, Hopkins was the first research medical school because of that. And also because Elizabeth Garrett gave the money to open Johns Hopkins, she insisted that women be allowed to enter. Oh yeah, thank you so much. So not only did people do medical school, but really the thing that William Osler here at Hopkins began is the concept of residencies. And that concept is you have somebody who's finished their medical school, and instead of going right into practice, that they do time with senior physicians, time seeing patients, time sort of interacting with more senior clinicians, and not just one as an apprentice, but a series of them. And really, that was very novel at the time. And really, by the middle of the 20th century, that was how medical education went. But for the most part, you know, really into the 40s and 50s, it was not unusual for physicians to do medical school and do a single year of internship and then go out into practice, especially in family medicine. Really, training for residents became a little bit more formalized by the 1970s. When we have the next slide here. So right now, so what now goes into, you know, these young physicians, these young medical students and residents? Really, they all have a high school education. They all do 4 years of college. They can do any type of major, but they basically take pre-health courses. And these are challenging courses: physics, chemistry, biology, statistics, and math. A lot of medical schools don't require humanities, but they always like to see those. Medical school is 4 years. It's 2 years of anatomy, physiology, chemistry, pharmacology, basic science, some pre-medical physical diagnosis, and then 2 years of mandatory rotations on medicine, surgery, neurology, obstetrics, pediatrics, surgery, family medicine, psychiatry. And this actually becomes that first exposure for a lot of them to patients, to people who have illness. And so, if you look at that, if they have 12 years of high school and 4 years of college, and then the first 2 years of medical school, many years have gone by before they've really even encountered somebody maybe who's been ill, or even has had a job because they've been students for that whole time. Next slide. So starting within their residency, what do we get? We have men and women. They're really aged 26 to 30 by the time they sort of encounter their residency. Many of their friends have had jobs for years, are married, have been in the workforce for several years, and they're sort of just coming out of their training. They are competitive and motivated and hardworking individuals because the way to get there has been so rigorous. It selects for a certain type of person. They are extremely good test takers. But the other thing to remember is most of them have loans from college and medical school really in excess of $300,000 a year, and that's on average. So they sort of leave their medical education with a mortgage on a house. But they have no house. All they have is the education they've had till that point. And now they begin a residency lasting, really between 3 and 7 years in duration. Next slide. So the next problem is that medicine is always challenging. The culture changes, the treatments change, imaging change, education change. And then there comes into this issue that I just want to talk about very briefly before Karissa and I start talking, which is the concept of generational conflicts. So next slide. So, you guys have probably all heard about this. Oh, I'm sorry. Can I have the next slide? You've probably all heard about this. The different generations of people, right? So baby boomers born before 1963 are productive and hardworking and team players and mentors. The Gen X which is what I am, I think, they have managerial skills, revenue generation, problem solving. And millennials, born 80 to 85, are enthusiastic, tech savvy. There are downsides maybe to each generation. Maybe that baby boomers are less adaptive and less collaborative. Maybe Gen X people are less cost effective and with less executive presence. And then my personal favorite, the millennials, are lazy, unproductive, and self-obsessed. So I think that, people talk a lot about this, and I think that this is one of the most harmful things in medical education. It is classic in American society for there to be generational conflicts. I definitely had generational conflicts that were mild, but had them with my mentors who were baby boomers. I wasn't there at the time, but I have heard, in history classes, I have gotten the sense that there was conflicts between the baby boomers and their parents, right? So the people who fought in World War II versus the people who grew up in the 60s, that there was generational conflict between those generations also. And what I would put to you is that this sort of like setting up people in silos is harmful. It's not true. Not only is it sort of stereotypical, but it actually can interfere with your ability to interact with learners and them interacting with you. So next slide. So I kind of like this slide, and I'm almost done sort of talking at you guys. I really like this because, this is the type of thing that people say about young people, right? So the children now love luxury. They have bad manners, contempt for authority. They show disrespect to their elders. They love chatter in the place of exercise, right? So, the kids today, they're so lazy. So the next one, our sires are worse than our grandsires. We their sons are more worthless than they, and so in turn we shall give a world of progeny yet more corrupt, right? Our grandparents were great, but kids today are terrible. And then I'm a warrior so that my son could be a merchant, so that his son could be a poet, right? I worked hard so my children can walk around and do nothing. So if you give me the next slide, the first quote is from Socrates, almost 500 years before Christ. The second one is Horace, 65 years before Christ was born. And the last one, before the Common Era, is John Quincy Adams, right? So this generational concept, this concept that kids are, that we're one thing, our parents are one thing, and our kids are something else, is human nature. It's just the way we view each other. There is no utility. There's no truth to it. It's just the way we move through things. My favorite quote about how we should interact with young people is the next slide, which is a Chinese proverb, which is, youth is to be regarded with respect. How do we know that his or her future will be equal to our present? If he reaches the age of 40 or 50 and has not made himself heard, then he will indeed be not worth being regarded with respect. That you have to wait. You don't know what people are going to make of themselves. You should regard them with respect because you don't know what they're going to be like in the future. So with that, just as this sort of concept, I think that is one of the big problems sometimes educators have with students, is not sort of being aware of these concepts. Why don't we have that next slide? So who are we talking about, right? Who are we treating? Who are the people who have illness that we're working with? So remember that medical school classes may be up to 50% women, which is a great thing. We're really treating the people who we treat are much more medical savvy than I was, when I was younger, and then my parents were definitely, because of the internet, because people talk, because information is freely flowing. People know a lot more. We are treating, to some extent, especially at Hopkins, to some extent, a distrusting population, a population that may be less, that may appreciate the efforts less, that may be less appreciative. You lose consistently. There's loss of skills and techniques that change so rapidly. One of my favorite stories is I had a chief resident who was in training 4 years, and that person was running a service, and they started an antibiotic that the junior resident started an antibiotic that physician had never heard of. And he was very upset. And I said, look, it moves so fast. This is why we work with residents, and this is why we work together. Medicine moves incredibly quickly. And also the number and the severity of patients ends up being important. So that's all the sort of talking at you I'm going to do. What I thought we would do is maybe Karissa and I would have a conversation about some of the aspects of medical education. So she is, so like I said, she's one of my executive chief residents. She's someone I view as an outstanding individual. So I thought maybe she and I would just talk about a couple of things. And these are sort of the things that I thought we would discuss. And we may spend more or less time on each individual thing. So, the reason why I wanted to talk about that background is that you have this really specific set of people, right? You have these set of people who've gone through college, they've gone through med school, and not that easy. Getting into med school is not that easy. And you don't necessarily select the most empathetic group of people, right? By putting them through this process. Now you need to, it's incredibly important. But any of you guys out there who have children in college, and the pre-meds have quite the reputation, and it is not one of empathy and caring. Maybe Karissa was better than me, but as a group, we don't have a good reputation. It's because we have a challenging set and we're trying to get somewhere. So how do we basically turn these people into sort of compassionate, empathetic physicians? Well, let me ask you a question, Karissa. So when you were in school, your colleagues in medical school, what were they like?
Yeah, I mean, it's pretty competitive, pretty cutthroat. Got to get the highest score every week on every test.
So cutthroat is slang that pre-meds use that I mean, it's old. I use that too. And cutthroat means is that only the highest percentage of people will get into medical school. So you have to, you compete, you try to work harder than everybody else. You don't necessarily, put anybody else down, but you are, you are not necessarily helping each other, right? I don't know, did you work in study groups in college? Because that was not how how we did things. Like, you didn't study in groups. I studied I did study groups in med school. I don't know, did you?
We did do some study groups in med school, because I think at least everyone is out there for one goal. And I was going to say, as much as we did have a term for the people who maybe were even more cutthroat, and those were the gunners. I don't know if you call them the gunners as well.
We did. And so it was there's a subclass of pre-medical students who, they would not necessarily, they would play mind games with you. They would try to throw you off game. They might tell you the wrong information or give you notes that were not, I mean, it is a competitive thing. And, the experience is relatively universal. I don't know, Chris, have you had experience of people who had different experiences than that?
Yeah, I mean, I do think that some things are changing over time. So even myself, I went to, a newer medical school. I believe now it's in its maybe 12th year or so. And they really try to get people in more study groups. And we actually try to study interpersonal education and working in teams to solve problems. And they're not necessarily, medical issues that we're trying to solve. They would just raise scenarios and have us work together as a team to come up with the best solution, and really kind of teaching how to identify people's strong points and weak points, and how to just work together. And I thought that was very useful, especially in putting some of that competition to the side.
So, I think that's exactly right. You have this very competitive group of people, and now that's great. I think it was, at least when I went to medical school, a lot of that sort of competitiveness continued through medical school, because depending on the type of residency you wanted to do. So for a very long time, students are really not taught to be empathetic to each other, not taught to work in groups, not taught to work in teams, and not necessarily to to be humanistic toward each other, toward people that you're going to be working with. So this, to some extent, and what I want to talk about is how we change that once they're residents, right? So it's beyond the purview for me to change how college works or change how medical school works. But what I end up trying to do is trying to take these group of people and make them humanistic, empathetic, caring, hardworking physicians that lead well and interact well, even though that has not been their experience up till now. I guess the other thing that I want to talk a little bit is how the internet has sort of changed things, how the internet has sort of changed not only medical education, but dealing with patients. So I'll tell you a story, Karissa. When I first started, there really was no internet. So what happened is that patients couldn't necessarily look up anything about themselves, look up their meds, look up their side effects, or anything like that. I think that's a different experience than we have these days.
Yes, definitely. Definitely have to be on your toes at this point. Dr. Google is out there, who definitely also knows a lot of information.
So let me ask you a question. How does it feel when you see a patient and they come with a whole set of ideas about what's wrong with them, and medicines that they think they should take, or diagnostic testing they should or shouldn't have?
So I think there's pros and cons to that. I mean, the cons is that you're kind of starting from a position where you want to start without any preconceived notion about the patient and what they might have. And so spending a lot of time discussing, thoughts that are already out there can sometimes lead you in a direction that maybe you don't necessarily want to go in. On the other hand, people who come in with that information about themselves and have ideas and testing that they think they should get, they understand their health a little bit more. They're interested in their health and the process. And so sometimes they also are kind of taking ownership of their own healthcare. And I think that that's really important nowadays as well.
Oh, I agree. What about, what do you think about the sort of not useful information that people can get from the internet?
That can be a lot harder, especially when you're trying to explain to a patient, the evidence that that might not support what they're coming in and asking for. And it can be really difficult because, people are going through things that you don't understand, and they read about this, potential wonder drug or wonder treatment, but that it might not benefit them, it might actually harm them. And so, it really puts a lot of pressure on that, patient-physician relationship and having an open line of communication, but also, making sure that you are doing what you believe is right for the patient as well, and making sure that you're not putting your patient at harm.
Right. No, I think that's totally fair. It's interesting. I think that people, almost everybody will, if they are having a problem, will use the internet to sort of figure out some way to think about things. And in a lot of ways, people can be really fixated on that. And I don't think that's a problem. Like, I always think that knowledge is useful. I think it actually makes the conversation easier in some way. I think people can become a little obsessed with it. Also, I think that some of the stuff on the internet is relatively sophisticated. Not that people are stupid or anything like that, but you can find things where there are half-truths, where there are things where it's kind of true but kind of not true, and that gets to be really scary, I think, for people. I think it gets to be really difficult. The thing that I find useful for the internet is that you actually get it out there, right? So people say, I've researched my symptoms, and you're like, great. So tell me what you researched, right? That's a good way to find out what kind of symptoms they're having, right?
Right.
And it's sort of organized in such a way. The other thing is that, I don't know about what your experience has been, but I actually haven't found almost anybody who doesn't understand that the internet is okay. It's all right. Otherwise, they wouldn't be there to see you. And if you can explain why the things that they've done are interesting but not necessarily relevant, people are usually open to that. I don't know. Has that been your experience, or have you had a different experience?
No, I've definitely had that experience. I mean, patients aren't necessarily coming to see us if they don't want our opinion. So they find something, online, and they think it's interesting, but they want to talk to an expert. They want to talk to someone who has training, in that area, and someone who can tell them if the information is actually backed up by, science, by the evidence.
Right. So one of the first things that we end up teaching, that we sort of, that I teach, and I hope that we teach within the residency, is, when people come with information, that's not necessarily a challenge, although it feels like one. So you have these residents, and they've come through a lot of training, and they've done an enormous amount of work, and then somebody has sort of spent 10 minutes on Google finding out about these things. And in the beginning, it can be daunting, right? Maybe you haven't heard of that. Maybe you didn't know about that website or that study, or maybe you hadn't even heard of that disorder. So it can be daunting in the beginning. And when you take somebody who's competitive and is used to knowing all the answers, and then you have this sort of instant ability to get all this information, it can set up really complicated interactions if the resident isn't A, prepared, or B, knows how to sort of deal empathetically with these situations. People come, with suffering with something, and they want to add to the conversation, right?
Yeah, definitely. And I found that, I've been in the position more and more where sometimes I just have to say, I don't know the answer to your question. I've never heard of this medication, or I've never heard of this disorder, but you're my patient, and I'm going to read about it. I'm going to learn everything I can about it. And then I'm going to come back to you with the evidence that I found, and, use my knowledge to explain it to you in a way that you can also understand. And so that we can kind of work together to figure out what's going on. So I found that there's definitely been a little bit of humility in this process, where sometimes you just have to say, I don't know, but I'm here to help you, and we will figure this out together.
So that's a fantastic point, Karissa. So, previous, not so much when I was in training, but maybe a little bit before me, you just never were allowed to say as a physician that you were either wrong or you didn't know. It's just not okay. And to some extent, when people didn't have free access to knowledge, there was there's nothing more terrifying, you know, for your physician to say, I don't know, because you have no other recourse. There's no other way for you to do research. There's no other way you think about it. There's no other way to use, you know, what we call the defense mechanism of intellectualization, which is something's wrong, and the way you work through it is you do research and you read about it and you talk to people. It was very hard to do that, and it's a really great defense mechanism. So it has been really useful. You know, so, but I do think that when we train residents, one of the first things we have to sort of share with them is, like, these are not necessarily bad things. You have to know how to deal with it, but these are not necessarily bad things. And today's physicians are better perhaps than they were in the past because of their ability to say, I don't know, but I'm going to find out. You know, I think that's extraordinary.
Mm-hmm.
So not to put you on the spot, and I am sorry, but I do want to talk a little bit about you know, being a woman in medicine. You're not a minority, so I'm not sure that you can speak to that necessarily. But do you mind if we talk a little bit about being a woman in medicine?
Sure. You know, I thought about this question a lot in the last few days and how exactly to answer it.
Sure.
You know, sometimes it really, most of the time, in fact, I think it doesn't really make a difference. It's not something I think about every day, that my experience might be different than someone else's experience. With that being said, I've definitely had interactions that, you know, were not the best, both from patients and from colleagues, or even, you know, preceptors when I was in med school. So where I went to medical school was generally a smaller town. Most of the physicians there are definitely white older men. There's not a lot of female physicians there at all, actually. And it's one of the missions of the med school I went to have more women doctors who stay around for this exact reason. And I remember on my first rotation ever, when I was going in to meet my preceptor for rounds, and I went into the physician lounge where I was supposed to meet her, and one of the male surgeons came in and, you know, just said, what are you doing here? And I said, oh, I'm a medical student. I'm meeting my preceptor here. And he said, oh, great. Now we're just, you know, taking anyone into medical school. And he kind of went on to talk about how women coming into the field has changed the way things work, and that now we ask for, you know, more time at home, perhaps, or at least kind of a work-life balance that has really come. And he almost blamed that on women coming into the field. And I just remember him saying, you know, I drive around my Corvette every day, and you'll be lucky if you can afford a Ford Focus. And he blamed all of that on women coming into medicine, which at the time I didn't really understand. So, you know, it's been anywhere from that to, you know, in that same hospital, they didn't have a women's physician lounge. They only had a men's physician lounge. You know, and I was just in medical school 5 years ago. So it's not like this was a really long time ago, you know. So it can go anywhere from those kinds of interactions, or, you know, people calling you honey or sweetie. You know, some patients also, you know, often will call me a nurse and not a doctor, which, again, I would never be offended to be called a nurse. I love all of the nurses that I work with, but I've also worked really hard for my degree, and I, you know, like to be respected in that way. So, you know, my experiences, I think, are extremely broad in that sense. And, you know, I wasn't sure whether to bring this up or not, but I do think it's important to talk about being a woman and thinking about also raising a family during, you know, you mentioned in here that most medical students are between the age of, or most residents are between the age of 26 and 30. And I mean, the fact of the matter is, as a woman, there's only so much time we have to have a family. And so these are all things that come up, and that we have to deal with that in a little bit of a different way, because there is a time frame that we have to look at in terms of family planning. And so I think there's just a lot of experiences and a lot of issues that women in medicine deal with that men don't necessarily deal with, and maybe don't even kind of realize are in the back of our minds as we're trying to work and take care of patients at the same time. I would never change it. You know, I've had great experiences as well. And sometimes I think as a woman, it can be easier for us to relate to, you know, our female patients as well, especially ones who maybe have never even had a woman doctor. And then all of a sudden they have a woman doctor who, you know, understands a lot of their issues maybe a little bit better. And, you know, I love those interactions as well. So I would never change it, but it is definitely a different experience.
Gotcha. Well, so that's really important because it sort of gets to, you know, the additional stressors, right? The additional stressors. So, you know, so now we have a population of people who are incredibly competitive. They've been put through the ringer. They are older. Sometimes they are, you know, subtly discriminated against because of their age or their sex or their ethnicity. And now you have this group of people, and what you really need to do is you teach them empathy and to teach them humanism, right? And you know, that's the problem that we have, right? Because of the society. So what kind of, you know, in your opinion, and then we can talk about other things that we've done, you know, what kind of things are done wrong to teach when people are trying to teach medical students and residents, you know, empathy and humanism? What doesn't work? You know, what do people think works but doesn't? You know, if you have an opinion about that.
You know, I do. I think it's really hard to, I mean, first of all, I think it's really hard to teach empathy from a PowerPoint lecture, which is what most of medical school is, right? And just,
totally, right.
We can talk about how important it is to care for your patients and understand their values and everything. But unless you're there in the moment with your patients and just talking to them, I mean, face to face, I'm just not sure that you can really understand that, especially if you haven't had similar experiences. And so I think the things that work, or the things at least that have worked for me and that I try to also teach the medical students that I work with, is you need to go to your patient's bedside. You need to pull up a chair, you need to sit with them, and you know, just ask them, you know, hey, you've had a stroke. How has that affected you? How is this going to affect you? Because I don't think that we will ever truly understand the answer. And patients might say something different, you know, for some people it might say, oh my gosh, I'm never going to, you know, be able to work again. And, you know, that's just horrible. And for other people, it might be something, you know, so small that you wouldn't even think of that they're worried that they're not going to be able to do. And so I think just really pulling up a chair and sitting with patients is the most important thing. One of the things I always like too is when we do bedside rounds, and I think a lot of places are doing that, including our residency program here at Hopkins, but also where I did internship at Bayview Medicine. Every week, you know, we present a patient, but rather than focusing on the disease process and learning about, you know, how the clinical presentation and the treatment, we go to the patient's room and we all sit with the patient and we just talk with them and just get to know them. Whatever they want to talk about, it might not even be why they're in the hospital. Some patients just want to talk about their grandkids and we just listen. And I think that teaches the most.
No, I think that's true, and I think that's fantastic. I think that, you know, there are a couple of other things that sort of we do that isn't always done. You know, I think that one thing is that knowing the person or being able to talk about the person is incredibly important. That's one of the things that happens at both campuses. You know, the person as a human being. You know, I think that medicine can be a little sterile, right? This is a, you know, 38-year-old man who comes with this, right? And the only thing you say about the person is how old they are, their gender, and, you know, and the thing that they're coming to see. And I think that teaching empathy and teaching humanism, the first step has got to be, whenever you have a patient, that there is some aspect of a discussion of who they are, right? And that helps you not only sort of to learn empathy, but also it gives you this visual image of the person, right? This is this person, they're this, they're that, they do this, they're this type of person. And I think that's incredibly important to not making the presentations dry, but also giving it a sense of realism. Like, this is just not a puzzle, right? This is just not a problem, that this is a human being. And I think they've done I think they do a very good job of that at Bayview particularly.
Yeah, I completely agree. And the other thing is, you know, the benefits to having these relationships with patients, it's really, I mean, it's obviously helpful for the patient to know that their doctor is interested in them and wants to get to know them. And but the other thing is that it's really helpful as a physician as well, to know that you care for the patient. And you know, when you go home at the end of the day, to know that maybe you stayed 30 minutes later and you just, you know, really got to listen to a patient kind of open up and tell you maybe they've been sad for a couple of days and they didn't really open up, and then finally you get to understand what's going on with them, and you go home and you really have a sense of pride when that happens. And I don't think that's something that you can teach. I think it's something that you have to experience. And once you experience that moment of pride, when you create that relationship with a patient, it's something that you will always try to include in your practice. And so that's why I think it's just important to really get to know your patients.
So I think that's true. I think the other thing that's sort of amusing for me is that at some point when you've seen a lot of people, the individual names begin to blur together, and even the individual diagnoses sort of blur together a little bit. And I know when I have residents, they'll say, oh, you know, Mr. X, he's, you know, 45 and he's got this. And I'm like, yeah, no, huh? Right. And they go, you know, this, and I'm like, I don't know, let's go see him. And I walk in the room and I say, oh, Mr. Jones, how's your dog? Like, is your wife any better? How is your child? You know, it actually is, it's incredibly difficult to remember things about people just based on their age, gender, and what's wrong with them. Because there's only, and there's only a finite number of things that can be wrong with people, but there's an infinite amount that can be different about people. And that ends up being incredibly important, I think, in being a good physician.
Yeah.
I think another thing that we have done is, I think that at Hopkins, we do two other things, which is, I think we try to model empathy. I think that the faculty try to be clear about the importance of it, that it's not just, you're not just sort of being empathetic because it's the right thing to do, but it's hard not to do something when people model it. I don't know, what do you think about that?
Yeah, I mean, I completely agree. One of the things I loved most that I remember back from my interview day was watching, you know, our chairman morning report and having the resident, you know, present the patient, and they said something like, you know, a 38-year-old male presenting with X, Y, and Z. And Dr. MacArthur just stopping them right there and saying, I don't want to know what they presented with. Tell me about the patient. What do they do? You know, what's their job? What do they like to do? What do they enjoy? Before we even started talking about why they were there and what their disease process was. And I absolutely loved that, because it frames the entire presentation differently, because they immediately start off to you as a person and not as a clinical presentation, not as a disease, but as a person.
Right. So other things we do is we sort of try to model it. We do have PowerPoint sort of talks about empathy, which doesn't work particularly well, does it? I mean, I think that one of the other things that we've tried to do is, you know, at the end of the year, we give to the chief residents, we give awards to the chief residents. And so there is an award for the best clinician, or there's an award for the best teacher. There's an award for the best researcher, the person who's done the best researcher. And, you know, as of 3 or 4 years ago, I started giving out the Richard Fogelson Award in humanism. And I think that ends up being incredibly important, because if there is somebody selected for it, if there is a tangible recognition, this is how physicians are built, right? This is how we've been like since we were in high school. So if you make it part of these are the things that are important to residency, and if you have humanism and empathy within that, and that there is evidence for it, and that people can tell you why that person won it, it actually ends up being incredibly important. It's important that there is not an award for everything, right? Because then it sort of dilutes it. But as soon as you begin to add, empathy and humanism to something that is recognized, that is deemed as important, and is identified in an individual, I think that actually makes a really big difference.
Absolutely. Yeah.
So let me ask you this: what within residencies do you think is done wrong in trying to teach people, trying to teach residents empathy and humanism?
That's a tough question. I mean, I think the truth is that sometimes we just don't get a lot of feedback when we are, when we're focusing on empathy. So some of the best residents and, that I've worked with, or the best mentors that I've worked with, are people who are always going the extra mile and working, not just an extra half hour, but an extra 2 or 3 hours, because they go back and they want to check on all their patients, and they want to walk in the room and say, how are you today? How was your day? What did we do right for you? What can we do better for you while you're here with us in the hospital? And, the one of the issues is that the next day, when you come in, nobody knows that you did that. And I'm not saying that we need that gratification each time, but it can get to be a lot when you're always going that extra mile and just not really getting that feedback. And that's when, it's nice when, and most of the time we do get that feedback from the patients or from families. And that's always really nice, but, it doesn't always come. And so sometimes that can be difficult. And we just have to always remember that no matter whether we're getting that feedback or not, that, we're making a difference. And we're making more of a difference, I think, sometimes than just starting a medication or treating a disease process. And, I think that's just one thing that can get hard. Right.
So I think that's true. I think that especially when you're talking about people who are not well, and who are having who are suffering or in pain or are suffering with an illness, they're often not in a situation to be able to do that. So, which is why it's incredibly important for you to get feedback from your colleagues and from your teachers. I think that ends up being incredibly important because, if you, to some extent, if you are always expecting your positive feedback to come from your patients, when we see them, these are the worst days of their life, right? It is, this is the scariest times of their life. It ends up being a situation where, that sort of back and forth relationship you have may not come for weeks until you've seen the patient as an outpatient and they start to feel better, and everybody begins to appreciate what a terrible situation it is and your role in it. So I think it's relatively important, and I think that your residency class does a really good job of feeding back to each other, of reinforcing really good behaviors, and I think that's incredibly important. Not only getting feedback from your colleagues and from your professors, but like from each other. And there's, if you don't mind me saying, I've seen you do it a bunch of times, and it's really wonderful to watch.
Oh, thank you. Means a lot.
So tell me a little bit about, what within residency is, really chips away at your ability to be empathetic, or to be, to talk to patients and interact with them and do the things that we mentioned.
I think this is something that goes back to how has the internet changed things, which is, having an EMR. And I think we spend 80% of the time sitting in front of a computer and documenting every single thing. And, even if we have a conversation with family, or a patient, and it ends up being this really good back and forth, if there's important information that came out of it, then we also want to go back and make sure that other people know that there was important information that might be pertinent to their treatment, and then we have to go and write another note. And it just feels like a lot of times we're just writing notes all day, and when it would be really nice if we can just spend all day with our patients.
So I cannot agree with you more. If the one thing that I see, the one thing that I think is the biggest difference between when I was in training, when you guys were in training, is just the sheer amount of of documentation that you guys do. I mean, you know, we used to document a lot. You have to write your history and physicals. You have to describe what happened. You have to talk about those things. But the amount of time that went into that was relatively low compared to what you guys do. And, you know, it's a really big problem, right? Because if you're filling out paperwork and you're writing notes necessarily, that's not helping the person, right? They don't care, or they shouldn't.
Right.
They don't, you know, it is less time than you can spend with people. It is less time that you're interacting with nursing, right? And interacting with social work and interacting with all the people who are working with us to help people. It's also a little soul crushing, right? It's a little soul crushing. You know, you see someone who's really great, who's really interesting, or who has a problem that you can think you can fix. And the next thing you think of is, now I have to, you know, write all this stuff. Yeah, you know, it is tricky that way. I agree. What about the number of hours that we work? Does that affect your ability to be empathetic, do you think?
You know, I'm gonna say no. I don't think it does. You know, even right now, so I'm on a rotation, you know, where I'm Bayview chiefing, which means that I'm working every day, 7 a.m. till whenever I leave, and then I'm on a home call overnight. And I have stayed late probably most days, mostly just because during the day I'm managing my team and we're rounding and I'm making sure things are getting done. And at the end of the day, when my team signs out, I sit there and I think, you know, I just don't really know my patients very well. And here I am with this whole team and I'm helping the residents manage everything, but I don't know the patients. And so most of the time, that's when I do my own rounds on the patient, and they really are more like empathy rounds. I'm not going in there for the purpose of, you know, what's their blood pressure, what's their heart rate. I'm going in and saying, hi, my name's Dr. Arthur. I'm sorry, we haven't really gotten a chance to talk. You know, I'm the chief resident on the team. I wanted to see how you were doing. You know, if I can help you with anything, if I can get you anything. And, you know, if I come home 4 hours later, just because I stayed to talk with a patient, that doesn't bother me. In fact, in my experience, that has actually helped prevent burnout, at least for me. You know, if I stay there writing notes for 4 hours, I'm burnt out. I just want to go home. I don't want to sit in front of the computer anymore. But if I'm sitting there at a patient's bedside and they're telling me a story, I'm not thinking in my head, I just want to go home. You know, I'm thinking in my head, wow, this is so nice. I'm fine. I have an understanding of what this patient is going through. And then I'm almost excited to tell the team about it the next day. Yeah.
How often have you, so that's great for you. How often in the sort of these interactions where there isn't a lot of pressure, you're not trying to get anywhere, do you find something out from them that's actually totally pivotal to what's going on with them?
Probably like more than half, maybe even three quarters the amount of time.
Yeah. It's you know, because what happens is that especially these days, you know, you see people, you do a history and physical, you talk to them, you make a decision about what it is, you send a whole lot of tests, and then the number of times after that you re-examine them or re-talk to them is less. You've gone down a path. And these conversations that you have with people that feel sort of easy and almost sound like conversations, you know, more often than I expect. You know, I usually expect that it's just going to be a social conversation, but it a lot of the times you find out something that you did not know that actually changes things. It's totally true. Yeah. And it's good for you too. I agree.
Yep.
How do you think that, and I think that we have about 10 more minutes. I want to make sure there's time for questions, but the last thing I wanted to talk about is how has it changed for you? And then how has it changed, you think, for people now that there's sort of COVID and our ability to be empathetic and humanistic?
Sure. So, I mean, the biggest barrier with COVID is that patients' families are no longer at the bedside. Yeah. And so, you know, 6 months ago, we would go or maybe 7 months ago now, actually, we would go and we would see our patients, and almost most of them would have, you know, at least one family member there at bedside who was a patient advocate. So they could advocate for their patient if their patient couldn't advocate for themselves, or, you know, at least be there to support the patient, as you said, like in a time where they're clearly suffering and in the hospital and in the worst days of their life. Now there's just so much anxiety and fear when patients' families are at home and they don't necessarily know what's going on. And, you know, we've also had difficulty kind of keeping up with answering questions, to be frank. So, you know, almost every day through rounds, we get messages, you know, this patient's daughter called, wants a call back for an update. And it's difficult for us to manage seeing the patients, putting in the orders, making sure that our direct patient care gets done, that patients are getting the testing they need, you know, the imaging that they need, while we're also trying to call families. So we're almost having two conversations, you know, one with a patient every day and then one with a family member every day. And that can become quite taxing. And, you know, a lot of those conversations need to be longer. They can't be, you know, a 5-minute update. Like, this is what we did today. This is what we're doing tomorrow. That's not how those conversations go, because family members are afraid.
Yeah.
And they're not sure what's going on. And that, I think that's been really the biggest barrier.
So I agree completely. You know, I think that when we, and I don't know about you, but I have to say that I didn't see this coming. So when COVID came out, and you know, it was scary because nobody knew what was going on. Nobody knew how it was transmitted well. People were doing really badly. You didn't know whether people were symptomatic or asymptomatic. You didn't know necessarily how to protect yourself. It was a lot. But keeping the families away from the hospital, I don't think I had any idea how incredibly detrimental that would be to people. It has been extraordinary, and you know, technology's been good. Like, you know, you can sometimes FaceTime, and I've had a couple of times where you've done Zoom with like the whole family and the patient, and that's sort of been fun to some extent, to sort of have those conversations. But it has been hard. And then the other thing that I've noticed is that, you know, when you're interacting with people, you know, if you can keep them informed, then, you know, the conversation is always really positive, right? If you can keep up with the concerns they have and what's going on and answer the questions, you know, that always works out well. And it's not only is a good medicine to be a good communicator, but it's, you know, it's good for you too. And the problem also, so the problem with COVID is that the questions and the problems build. And so by the time you sort of talk to them, everybody's upset. Yep. And then you go, okay, now I have to explain this. And then it's these poor people, and you have to, you know, you're trying to explain to them what's happening, and you can't, you know, I can't even imagine what it'd be like to be at home as your loved one's in the hospital. And that sort of adds an interesting, you know, complexity to it too. I think that people have come up with all these different sort of technological ways around it, using Zoom and using iPads and things like that. But it's not quite the same, is it?
No, it's definitely not. No.
Yeah. Have you found a technique that you like to use to sort of mitigate that and sort of move around that?
So when I know most people have one kind of family member that's designated as someone we call and talk to, and then tells the rest of the family. That's been helpful, so that, you know, we're not calling 3 different family members for every patient. And then for people who are tech savvy, I've generally been, you know, FaceTiming or Zooming with them when I see the patients, that we can all be in the same room.
So, you know, the other thing that you did that I was really impressed with is that when we were working in July, you made sure that your residents called your patients' families once a day. And that was part of what they were supposed to do. And that, you know, and that if they had a hard conversation, that they could come to you and sort of talk about it, and maybe you would take over, or maybe you would sort of help them move through it. But, you know, not waiting for problems to occur, but really, you know, speaking to them, keeping people appraised. And I remember a couple of times there were some really rough conversations that you took over from your more junior residents to, and I felt like modeling how you're supposed to do these things. So I thought that was impressive. How did that just sort of occur to you naturally, or had you seen that done before?
I guess I had been doing it early on in COVID. This was, when we were kind of managing the teams on our own and didn't have junior residents.
Yeah.
And so I think in my head, it was just an expectation as the provider for the patient to update their family. And so, when I started chiefing, I just kind of continued that. I'm still continuing that now as well while I'm at Bayview. So my residents still know that they have to call their patients' families. It's also been really helpful for the patients' families to know that, between the hours of 4 and 6 p.m., they will expect a phone call with an update. And I found that that's very, very helpful when they have a set time that they know that they will get a phone call as well. So that it decreases that sense of anxiety of when am I going to get an update? And, it's been very, very helpful.
No, I remember. I remember distinctly. And that was, I think that, that's often hard to do, but I think that's incredibly effective. And the last thing I just want to talk about in the waning minutes is telemedicine, and how you teach empathy and how you teach humanism and how you teach good bedside manner and all these things, because there's a lot of telemedicine now, right? Because of COVID, there's a lot of the patient evaluations I do are over the computer. There are sort of more conversations. You're doing telemedicine with, and then you're also sort of doing tele interactions with the family. What kind of things have you done? Any of those?
I have. I had some real concerns about telemedicine initially. How are we going to do a neurologic exam via video? We can't look in the back of the eye. We can't test reflexes. We can't test strength. How are we going to do? And to be quite frank, it's been a little bit fun. My cat will jump up on the desk and, my patient, and then we just can connect by that. And we just appear more human and more personable to each other. And then being able to see where my patients live, what is their home life like, talking family members through trying to do a motor exam has also been very fun. And so I feel like it's given just a new kind of deeper relationship with my patients. I remember there was one person who, had a Titanic model in the background, and you can't see it, but there's actually one on a shelf above my head as well. And so, just having that little interaction and finding that we both have a common interest was also really fun.
So I agree with you. I have to say, I thought it was going to be the most sterile thing possible, and I was so worried because I think that I try to have really meaningful interactions with the people who see me for their problems, and I think it's actually really important. And I was like, I'm not going to be able to practice medicine anymore. I can't touch them, and I can't. But you can do lots of things, right? You can actually really bond over. And I have had a lot of bonding experiences with trying to teach family members how to do aspects of the neurologic exam. And I have been incredibly impressed with people's ability to do that. It's been extraordinary, actually. So, and I don't think that aspect of medicine is going away. So I'm really glad that you got to learn it under these circumstances, and not when you were, middle-aged and having to sort of, figure your way out of it. So that's great.
Yeah.
So is there, I think we should probably think about taking questions because it's sort of at the top of the hour. Are there other things, Karissa, that, along these lines that, I forgot to mention, or, you wanted to talk about before we moved on to hitting up some questions?
I don't think so. It looks like there's some interesting questions here, so.
Okay, all right.
Yeah,
all right.
Thank
So
you guys for the discussion. I can go ahead and read the questions for you.
Sure.
As neurologists and neurodevelopmentalists, we are often in a position where we're delivering bad news about serious medical diagnoses to patients and families. How does this change in the times of telemedicine and when one has to don PPE when families are not receiving nonverbal cues? You guys talked about this a little bit, but.
So that is incredibly important question. It is. So so why don't I start and then I'll have you finish, and I want to hear what you have to say too, Karissa. The most important thing that you do as a physician is give bad news that is clear, that is unequivocal, that is empathetic. And it is hard to emote through PPE, through a face mask, and they can't see your face. I think that there's a couple of things that you can do. What I end up doing is, for the most part, if you're feeling it, people will pick it up because they're looking for it. They're looking for any evidence of it. And so you can show it in your eyes, or you can show it in your tone, you can show it in all sorts of ways. I tend to do things like I try to get below people's eye level, right? So I don't sort of look down, you basically, if they're in bed, you don't look down, you basically get to their level or slightly below. You get close so they can see you. I will not say that I've ever removed my PPE during these conversations. I will not admit that over this, but I could imagine a situation where that might happen. You end up, but I think that the secret is that if you feel it, people are desperately looking for it and they'll pick it up. You just can't be self-conscious about it. You just have to sort of be yourself about it. I don't know, Chris, I know that you've had to do this a couple of times during this period of time. What do you think?
Yeah, I mean, so one way, if, not all bad news is horrible bad news, and sometimes patients' families still actually can't come into the hospital for some news. And so I find it helpful to use Zoom or FaceTime because they can see your facial reactions, and I make sure I sit somewhere where I'm able to remove my mask in those situations so that they can see my facial expressions, because that is extremely important. And
Yep.
I ask them to actually do the same thing, because it's also important for me to be able to understand their nonverbal cues as well. And to know, sometimes we could tell if they're not understanding something, or maybe they just need to pause and, absorb what was just said. And so that's extremely important. If we're in a situation where we're wearing PPE and mask, sometimes it's okay to put your hand on someone's shoulder, and it's okay to hold someone's hand and just pause, and you can show that, what was just said was important, and that you heard it, and that you're with them, and that this is hard. And, that's something I've always done, and have just continued to do now. It's just, there's a glove on now is really the only difference.
Right. No, I think those are great. And you are right. You are right. Zoom and FaceTime are much more useful for them than I would have than I ever expected.
Mm-hmm.
Okay, next question. How do you balance getting to know your patient so personally with keeping objectivity? Also, how do you manage your own emotions if you don't have this intellectual separation? For example, it must be challenging to know these patients so personally and then watch some of them suffer or pass away.
So that is important. So, you're not supposed to treat your family as a physician, because you can't make objective decisions about them. You aren't supposed to treat your children. You're not supposed to treat your wife, because you can't make the hard decisions about it. I do think that I'm not necessarily advocating for people to become necessarily friends with all their patients. Like, it's not necessarily one of those things. I think an empathetic conversation is and knowing them and sort of having some interaction with them ends up being important for your relationship with them. That being said, I mean, I don't know if this is a popular opinion, but when your people pass away, it's supposed to hurt. It's supposed to be that way. It is supposed to. It's supposed to sting. And your patients don't want you to suffer, but they also don't want you to think that it doesn't affect you. So I think it is incredibly important that those interactions are present. I think that's a hard thing for physicians. I think especially in the past, we were taught, like, you don't get too close, you don't get too personal, because you don't know what's going to happen to them. But what that leads to is a cold relationship. And when there's a cold relationship, if you have a cold relationship with a physician, the likelihood that people are going to follow your advice is less. So you have positive, empathetic interactions with them, so that so that they will listen and understand what your opinion is. There are some people that you're going to have a hard time merging with. There's that you're going to have a hard time clicking with. That's okay. But that doesn't mean that you can't be there for them and empathetic and have these type of interactions. I don't know. What do you think, Karissa?
Yeah, I just want to second that. So I agree that I think it's a myth that you shouldn't get to know your patients, and it's okay to have feelings. And we're human, right? And we have experiences. Some of us have experiences that are similar to what patients are going through. And I don't think it should be an expectation that those completely get put to the side. Mm-hmm. I just want to share a quick example that happened to me during COVID, but I was taking care, of an older gentleman on our neurology service, and every single day he was a talker, and every single day we would round on him, and we would round on him last because, we would have to put 40 minutes aside because he would tell us all about his grandkids and all about his kids and all these stories, and we would listen, and it brought him joy to talk about his family at a time where he's stuck in the hospital, not able to communicate them. They weren't able to see him. He had been in rehab for months before this, and so he hadn't really been able to see his family at all. We really came to like this patient. We got used to seeing him every day, and we got used to seeing to hearing his stories. He actually, unfortunately, did pass away, and I unfortunately had to deliver that bad news to his family, and it was sad. I mean, and I'm one that thinks like it's okay to shed a tear when you're with family, and it's okay to show that you also have emotions. It's not okay to bawl your eyes out and have to rely on family to help you, but it's okay to show that you're affected. And the other thing was, in that situation, just even going back to the empathy, I was able to tell his family members, all he talked about was you. He told me this story. He told me that story. He talked about, your daughter and this recital she was in. And when I shared those stories with the family, they were just blown away that, that we got to know their dad so well. And it ended up, as much as we were delivering bad news, it kind of turned into this like beautiful conversation where we were just sharing stories back and forth. And I mean, how is that not supposed to affect you? Of course it's going to affect you. And of course you're going to be sad, and that's okay. There's just a limit, and you still have to be the provider, and you still have to be the doctor, and you still have to be professional, but you can be professional and still be affected and still have feelings.
I think that's a great answer. Thank you.
Mm-hmm. Okay, last question. Do you have any recommendations for incoming interns on incorporating daily habits to not let the time towards documentation overshadow meaningful bedside care and knowing our patients well?
So, boy, is that so? We all spend a lot of time trying to, like I was saying, it's a new skill set. It's a new skill set to learn to be empathetic, because of the, people come in with empathy, but it hasn't something that's been rewarded in the past. My advice would be, don't give up a chance for victory. There is no victory in writing notes. Don't give up a chance to talk to a patient, to do a procedure for them, to look something up, to talk to a family, to be a physician. And then, there's a lot of pressure. There's a lot of pressure to oh, I don't do this and I don't do that. And I don't, I don't need to talk to them. I don't do these things. Don't give up an opportunity for you to have a positive interaction with people. And, that can be a procedure that you have to do, and you do it well and they don't feel anything. Or that can be, talking to them, or that can be researching what their problem is, or that could be spending time looking for the results of tests that were done elsewhere, things that you're doing for the person. I think what happens is that in a lot of ways, what interns will do is they'll say, well, the notes are what I have to do. That's what I'm going to get in trouble if I don't do, but I don't have to do these other things. You don't ever give up a chance for a victory. And, you know, a victory is talking to a patient, examining them, find something you didn't know was there, learning something you didn't know, having a meaningful conversation. Don't give up the opportunity to do things like that, because you can.
I just want to second that. When I was an intern, because I was not an intern very long ago, you know, right around January, February, I got extremely burnt out, which is very common during intern year to get really burnt out in the winter. And the only thing that helped me was incorporating that afternoon rounds into my schedule. So that's something I've been doing since an intern. So every single afternoon, I would try to finish all of the urgent work that I had to do. And then usually around 4 or 5, I would go and just say hello to all of my patients. And again, it wasn't a long conversation. It was just, hi, you probably remember me from this morning when I was standing with a group of 8 people, but I'm Dr. Arthur. How can I help you? And how are things going? And do you have any questions? And that was it. And for whatever reason, that just, it honestly helped me with the burnout. It made me feel like my job was more meaningful, because as an intern, sometimes it can feel like what you're doing is not meaningful. You feel like you're writing the notes, you're putting in the orders, and you're doing, you know, the quote unquote scut work. So doing this and talking to the patients brings that meaning back. So even though, sure, it takes a little bit of an extra time, it takes some extra time, I think it's worth it to incorporate. I don't have an easy, if the question is, you know, how can you easily incorporate it into your schedule? There's no easy way. And I think it is going to take some time, but I think that you will find that that time is worth it.
I think that's great. I think that the other problem that sometimes that interns have is that there's an anxiety about talking to people who are sick, right? There's an anxiety about talking about, you know, exploring these things. And that's something that has to go. That's something that you have to get rid of. And that's a very good way to sort of let that go, because you find very quickly that when you, I bet you, because, you know, I've done that often also, is that no one's going to ask you, you know, this is not a quiz. They're not going to ask you something that you don't know the answer to. You're just connecting with them, right? I think that's great.
So we are out of time. We're actually past time. We'd like to thank our speakers for their time and talent. We'd also like to thank you for joining us for today's webinar. A follow-up email will be shared with you following the webinar that will include a recording of the program, along with a list of resources and our event schedule. We hope you will join us at a future webinar. Thanks again.
Thank you.
Thank you guys so much.